I think we're, oh my gosh. Very professional. Hi everybody and welcome to the dedoc Symposium at this year's ISPAD. My name is Renza Shibilia. I am the Head of Advocacy for dedoc and I am an advisor to the team. And I'm so thrilled to be here today and sharing this session. And thank you to everybody who came. This is such a brilliant session because we are going to feature and highlight people with lived experience of diabetes, who I believe are always the most important people in the room anytime we're talking about diabetes. So let's skip that photo. I'm so delighted also that I get to now introduce another Australian. It's a bit Aussie proud right now. And I'm going to actually introduce for us the president of ISPAD. ISPAD's very precious to dedoc because it was the first conference that we had a dedoc Voices program. And so the support of dedoc has been just, of ISPAD, sorry, has been just so important to dedoc. So Fergus, please come up. And I'm looking forward to hearing what you have to say. But also we do want to say thank you for the ongoing support of ISPAD, of making sure that there are people with lived experience as part of this really important conference. So thank you.
Thanks, Renza. You guys are really important to ISPAD. We're really, really proud that we were the first society to have a dedoc symposia, only by 6 months from ATTD. It was a near-run thing, but we won, that's the main thing. And there was a bit of a debate, it was 2018 or 19, the opinions were split in the EB, they couldn't quite remember, it's a COVID sort of fog thing. But it's a long-standing relationship, and it's getting better and better. And this year in particular, to have somebody with lived experience on the scientific committee was really just given the whole meeting an edge that it really is excellent. I've got to confess, so I've only been the ISPAD president for this year. It's a 2-year thing, so you don't get to do it for very long. And I've met Bastian, I've met Anna, and Renza and I go way back. We've butted heads many times. So I know a little bit about dedoc, and I read the website. But I feel I don't know enough, so I'm going to spend this afternoon sitting in the symposium, and I'm here to learn. It comes with one caveat. Like Renza, I come from Melbourne, and from a jet lag point of view, this is about the worst city on earth to be on. So if I zone out a little bit in one of these sessions, it's not through lack of interest, it'll be lack of cortisol. So just bear with me. But I'm here, I'm really, not just me, our whole EB are just so proud of our arrangement with dedoc, and I'm here to learn.
Thank you. And yes, this is a beautiful city. Can I just start by saying that? But yes, in terms of time zones, it is very challenging. And this particular time of day, I think as well, is a little bit challenging. So we'll throw things at you, Fergus, if we see you nodding off. So that's fine. Okay, so introducing the dedoc Voices. And look, Fergus, we can help you here because we've got the year that we first started, and it was 2019. So there you go. But you're right, the COVID years has made time very confusing. Let's start, if I can, by asking everybody in the room who is a dedoc voice to stand up, please. And obviously all of our people on stage as well. Please have a look at these people. And the reason that I am encouraging the people who are not dedoc voices to look at these incredibly wonderful advocates, people with lived experience of diabetes, is because you will see them around the conference for the rest of the week. Please go and talk with them, with us. Come and talk with us and ask about how lived experience and why lived experience is so integral in all aspects of diabetes, why people with diabetes have a really, really critical place at diabetes conferences. And to all of our people with lived experience, the words that I say every single time is thank you. Thank you for showing up. Thank you for being here. Thank you for sharing your expertise and your experience and your knowledge of diabetes, because there is an emotional labour in that. And I'd like everybody to recognise that as well. When we share our stories, we're reliving again the story perhaps of our diagnosis, or often of really difficult times, or of difficult periods where we've really tried to advocate but we've been pushed down. So thank you for showing up and for sharing those stories. And you may now sit down. Thank you. All right, so as you can see here, the dedoc Voices program has a lovely history. It's a very powerful history where we started off with one conference with ISPAD, but we have now visited a lot of different places. We are now part of ATTD, EASD, we've been to ADA. This year we went to Diabetes India. Diabetes UK has welcomed us. Everybody wants dedoc at a conference because we bring that lived experience. We look good because we are enthusiastic and we are vibrant and we want to talk about what it is that we're doing. So we understand why everybody wants us at all of these things. Take advantage of that and come and have a chat with us. This can't happen if we don't have support from our partners, so thank you very much to them. We are so grateful for the support that you have given for the program to have started, to have grown, to have been where it is, and we ask that you please continue to support us. Nothing about us without us is one of the mantras of this program, and that means that we need to be here. So thank you for helping us get here, and we are so desperate that we are able to continue that moving forward. Conferences really would be very different places without people with lived experience, and I don't think we want to go back to that. I really don't. Now, that's probably enough from me. I like to be a very light touch chair, I've got to say. We have got the most remarkable panel. And I'm going to stand up and just say their names and pretty much that's it. And then they are going to do the rest as they share the incredible work that they're doing and how it impacts their community, and introduce themselves as well. So Lindsay, could you please come up? I am just going to say, Lindsay is from Canada and has been such a huge and important help as we have brought this all together. I admire every single person on this panel, and so will you if you don't already. And I'm delighted that Lindsay's going to kick us off with the work that she has been doing. So thank you. Now, I'm really good at technology. I'm not good at technology.
We're just trying to get Fergus's cortisol up.
Yeah. There we go. Look at that.
Hi, everybody. Thank you, Renza. Thanks, everyone, for joining us today. So my name is Lindsay McCauley. The X is supposed to be there. And my full-time job is managing my diabetes, and my day job is the Director of Patient Engagement at an organization called Diabetes Action Canada. So DAC is a research network that works from coast to coast to coast here in Canada, and our work is to connect the 4 L's of expertise in diabetes, those with lived, loved, learned, and labored expertise. So as Director of Patient Engagement, my job is to create the processes, infrastructure, and ways that we can bring folks with lived and loved experience. So I have lived experience because I have a diagnosis on my chart. My husband has loved experience because he doesn't know what it's like to live with diabetes, but he knows what it's like to be the partner of someone with diabetes. So I work with folks that have lived and loved experience and connect them with those that have learned and labored experience. So learned expertise is our researcher friends. Labored expertise would be clinicians, community health workers, nonprofit workers, charity workers that are working with communities day in and day out. And I'll caveat that most of us are 2 FERs, 3 FERs, and 4 FERs. We wear many L's of expertise, but DAC is there to connect the dots so that we could co-design, co-publish, co-deliver research and policy programs to improve the lives of those of us living with diabetes, and do it in the dedoc way of nothing about us without us. So one of our flagship programs, and what I'm really excited to chat about with you today, is our Research to Action Fellowship. So what is the DAC Fellowship? It's a 9-month paid program that works with patient advocates, and we are with them for about 9 months, and we teach them things about marketing, research, communications, accessibility, community engagement, participatory science. And really what the fellowship is looking to solve is that 17-year gap between research being published and those publications being implemented in care settings. So we know that, I actually think it's way longer than 17 years, but the most recent figure we have is that it takes 17 years for something to go from journal to practice. So we ask the question, how can we work and actually lift up community voices to close that gap? Because no one knows better than we do what we need at the community setting. So the patient advocates work in teams of 2, and they take published evidence-based research, peer-reviewed, and they create projects with partner organizations. Everything from flashcards to comic books to videos to an AI chatbot to get that research into the hands of those of us that need it every single day. And we ran it for the first time last year. So it took about 2 years to co-design this fellowship. And I will mention that people from 16 to 78 years old helped co-design the program from actually 16 different countries. Everyone was compensated for their time and their input. They helped us design everything from what trainings we offer to how it's delivered. And we ran it for the first time last year, where our 8 inaugural fellows created advocacy flashcards for Indigenous self-advocacy. I'll touch on that a little bit today. Comic books about patient interactions in healthcare, especially for folks living in larger bodies. Culturally relevant vignettes for South Asian and Black communities, and infographics on mental health and diabetes management. So I'd be remiss to not take a moment of these precious 7 minutes to talk to you about who the fellows are, because I wouldn't be here talking to you about this program if it weren't for these incredible people. We had over 80 people apply for our first cohort of the fellowship, and the 8 inaugural fellows were Ryan and Roseanne, Natalie and Jeremy, Cindy and Sanaya, and Matt and Al. They have a variety of lived experiences from type 1, type 2 diabetes, homelessness, blindness, kidney disease, also a lot of joy and a lot of wisdom and cultural learning. Some of them love people with diabetes. Some of them are also healthcare practitioners themselves. So I'm privileged to be able to share their work with you today. So I want to touch on Ryan and Rose's project, and before I tell you about the flashcards, I want to also shout out the incredible partners that helped to make this work. So each team of 2 fellows works with a community organization that mentors them. And Celeste is in the room, and I'm going to make you wave. She was Ryan and Rose's mentor from the National Indigenous Diabetes Association here in Canada that helped make these flashcards happen. So Ryan and Rose took about 16 published papers and created a set of 8 flashcards to be used at healthcare settings. And the flashcards say everything from, hey, I don't want to talk about this today. Please talk about something else. Or, hey, can you explain this in a different way? I need you to communicate it differently. They also have some topics like, hey, what exactly does A1C mean? Can you please explain carb counting again? Or we added a flashcard called, I need a sugary drink right now, it's urgent, because our community said over and over again that actually one of the things that they really wanted support with is telling flight attendants and train attendants that they need a Coke and they need it now because they're going low. So community told us what they needed. Ryan, Rose, and Celeste helped make it happen. The flashcards are all color-coded. Ryan lives with vision loss, so they're actually all available in Braille as well for free. And the artist that did the art for the flashcards was also Indigenous and lived with diabetes. And we also had 29 community members participate in the co-design, everything from color and symbols to topics of the cards. Really, what I want you to take away from this work, besides the QR to the flashcards at the end of the presentation, is that this happened because we did it with community, not for community. Every single resource is co-designed by over 90 people with lived and loved experience. We pay for over 4 to 5 different co-design sessions to help make all of these decisions. And we get community feedback and expertise on everything from design to content, but also how we share things out. So Ryan and Rose have shared these at a variety of community healthcare conferences, but they also give them out at cultural events, and they give them out at mental health centers, and they give them out at daycares because they know where they need it the most. We learned that co-design is the only secret sauce, really. We could have all the research we want, but if we don't have all the voices at the table, it's very hard to not only close that 17-year gap, but we make it wider. Diversity of lived and loved experience matters. I don't know what it's like for any of my other fellow dedoc voices to manage their diabetes, and that's why I'm privileged to learn from all of them. So it's not enough to just have a couple of folks with lived experience at the table. That's why we have the fellows and community co-design sessions. And who leads that work also matters. So it's Ryan and Rose that were at the decision-making table with mentorship from Celeste and I and the rest of the team. But at the end of the day, it was them who decided when researchers told them, you don't need an A1C card, everyone knows what A1C is. They said, no, we need it. I can tell you why, but I know that we need it, so we're gonna make that card. And when people told them that they don't need the card about, I don't wanna talk about this during this appointment, that's actually our most used card by all people, not just Indigenous communities, by folks from 116 different countries have used that card in the past year. So leadership also matters. So what's next for us? Well, we're running the program again this year. This year we have 10 fellows and 5 partner organizations, and we have projects on women's health and cell therapy, and a variety of other projects. Most importantly, we're going to share how we run this program. We're going to publish an open source evaluation study of what worked, what didn't, and how to do it right. And next year, we'll publish a free implementation guide as well. So I hope that not only do you download the cards, please download them, use them in your appointments, but also think about how you can maybe implement something like this in your communities, and help close and shrink that 17-year gap. Thanks so much, folks.
Thank you so much. I know we talk about the 4 T's of diabetes all the time, right? When we're talking about the symptoms of diabetes. So thirsty, tired, toilet, thinner. These are the symptoms of diabetes. Know these symptoms, be aware of them. If you're experiencing these symptoms, go and ask your doctor about type 1 diabetes. But I'll tell you what I have been using even more than the 4 T's throughout this year since I heard Lindsay first speak about the 4 L's. 4 L's of? How do you describe it? The 4 L's of expertise, and I think we need t-shirts. We need team t-shirts, and we need to be talking about that because each of those areas brings a unique perspective and unique expertise, and the combinations of all of them is so valuable. So I hope that you all think about this now when you go away and think about these 4 L's. It's really, really powerful. Thank you so much. Okay, I'm now going to bring Apurva up to the podium. And is that starting? I'm really good with technology. There we go. All right, we're good. Thank you so much, Apurva.
Thank you, everyone. First of all, thank you so... Oh, sorry. Okay. Thank you so much, everyone. First of all, thank you for prioritizing this event in such an amazing conference because ISPAD, for me, is so special. I attended my first ISPAD in... Okay. It's After Effects. So I attended my first ISPAD in Hyderabad in 2018. And this is probably every year I have prioritized this conference to be there because it's so special. So I'm here because I really want to wear multiple hats right now. But the one hat which I'm here for is I live with type 1 diabetes. And I've been living with for the past 18 years. And I really want to talk about one thing which you guys should take away from this session is what can you do when you step out of this room? Because everyone can make a difference, and that's why we are here. So you all must be wondering, why is she talking about sickle cell disease, childhood onset heart disease in a diabetes conference? And that's what the whole thing is about. So let me say, so I was born and raised in Delhi, India. And, one second. I was born and raised in Delhi, India. And I was diagnosed at the age of around 13, 14. But before that, I was dealing with a lot of stigma around my diagnosis. But fast forward, I really wanted to be a doctor. So I went to medical school and saw diabetes from a very different lens. And that's what pushed me to really step out, get into the global health space, and figure out diabetes does exist across our boundaries, that's how the world has been separated. And that really opened my eyes to a different world. Years later, working in hospitals in Malawi, Liberia, through my current position at Center for Integration Science, where I'm the Associate Advocacy Director, I met young people with very different outcomes. And that's what that's one of the reasons why you see three different, very different conditions, but one shared truth, that our health systems treat people as if live on separate islands. One island for diabetes, one island for sickle cell, but in reality, they share the same waiting rooms, same doctors, the same struggles, and the same pain challenge and the same stigma. And I know you might be thinking, but how does it make a difference to the world of diabetes? So that's where I'm going to bring you what our session for ISPAD started with. And Dr. Wolstorff, in his presentation, made this really powerful quote: "No man is an island entire of itself. Every man is a piece of the continent, a part of its main." And in global health, we've all often built islands. If you go to a WHO conference or a UN high-level meeting, all they talk about is single diseases. And people don't live in compartments. Our health systems shouldn't either. And that's exactly why I am here today. One goal in the next few minutes for you to take away is, first, what exactly are we talking about in Pen Plus? And second, what is the hope that Pen Plus brings to people living with diabetes, sickle cell, and childhood onset heart disease? So there is a huge disparity. Where a child lives never should determine whether that child lives. And yet, that's the reality of so many people living with type 1 diabetes in Southeast Asia and Africa. No disease should be treatable in one country, yet a death sentence in another. And why is this disparity? Because our health systems have been structured like that, and it will fail. And that's what pushed me. While training in medical school, I saw diabetes from a very different lens, and that's what pushed me, that I am so privileged. I should step out and see how I can make a difference. And that's why when you all step out from this room today, you all have to make a difference, because you bring such a critical role, play a critical role, and bring such a great value to how we are making care available to all. So like you heard from Lindsay, the word co-design, and I love that word because co-creation, co-design is the way to go, and meaningful engagement is the way to go. But why are we talking about integration? Why are we bringing three different diseases under one umbrella of Pen Plus? You might be wondering that this is another word of integration that looks good on policy papers, but it doesn't look good on practice, because integration is it about combining clinics or bringing medicines to one place? It's about connecting people, it's about connecting experiences, it's about connecting human shared values, and it's about breaking those silos across disciplines, because people with lived experience can bring a lot, and clinicians and lived expertise has to go hand in hand. So to optimize the scarce healthcare resources, Pen Plus is a model of care that trains nurses and clinical providers to bring care closer to home. So for a long period, people had to travel almost 100 kilometers to get to a tertiary care center. Many never even got insulin in Africa, and they just died silently thinking it's just malaria diagnosis. So that's why we are trying to bring this model closer to home by training people who can really provide care at district hospitals. So Pen Plus strengthens the existing WHO Pen services at lower level facilities, and that's why I was so passionate to join this group after my training in public health. And I said, I really want to contribute, and how I can contribute my lived experience. So what is very powerful about Pen Plus? And you would be wondering what PEN really means. It's basically a package of essential non-communicable diseases. I'm not short on time.
No, we didn't know what PEN was. Can we hear what PEN is, what it stands for? Keep going.
Okay, so a lot of people are wondering, oh, but what is PEN? Like, who made this acronym PEN? PEN is the package of essential non-communicable diseases, and it's not that I made it or somebody else made it. It's a WHO-endorsed terminology, and it's a model that's already existing in many of these countries. And PEN Plus is just a level up to focus on severe chronic NCDs in children and young adults. And that's why it's not just a model or a pilot, it's a very implement-friendly it's the design, it's the people behind it, the nurses, the advocates, the ministries, and the lived experience leaders who are all part of the same story. So far, what Pen Plus has done, it's so powerful that it has expanded to more than 100, almost 100 Pen Plus clinics with more than 4,500 people who are living with type 1 diabetes receiving care. And this is the update we also gave during the executive board meeting, because we are really collaborating with ISPAD and all the people in our partnership through UNICEF, through CHAI, in trying to expand this model, increase the training, and ensure that people receive the quality care they deserve. But the most important part is why I'm here, is because I lead the advocacy part of the Pen Plus area, and the most amazing program I'm very proud of is the Voices for Pen Plus. And like how Lindsay started her research fellowship, our Voices for Pen Plus initiative actually started as a fellowship initiative, and now it has grown to be a co-designed, co-created initiative where people just are part of the decision making. They're part of steering committees. They help us design programs, and they also help us think about these diseases in a different way. So advocacy isn't a responsibility of one person, but it's a partnership. And it starts not just from the clinics, but from level to the policy level. So this was a statement I think was made by Emma, that it's a responsibility for all, and that's where you all fit into this picture. So the Voices for Pen Plus, many of who are sitting here, and you know who that is. Tino is right here. He's been such a wonderful person who has helped us shape the Voices for Pen Plus program. The Voices have positioned themselves as a key stakeholder involved in the steering committee. They also help in designing special projects on the ground and also designing peer educator trainings at clinics. They're working with the ground physicians and implementing partners to design what should go in the training manual when we all work together. And the last piece, which I want to really highlight, and I want to leave you with this picture, is advocacy is for all of us. Pen Plus shows what is possible when we bridge science, systems, and stories. Breaking the silos is how we make systems heal. And if you have to remember just one thing from this talk today, and why I'm passionate about Pen Plus, is it really thinks about equity in its design. And it breaks silos between diseases, disciplines, and doesn't see things as separate islands, but one continent where everybody deserves the quality care it needs. And this picture really sums it up, that so many people with type 1 diabetes and sickle cell came along together in one camp, working with the physicians and the camp counselors to identify what they can do to bring care closer to home. So if you would like to learn more about Pen Plus and this model of care, I think you can come chat with us in the booth at the booth 16.5, which is a very odd number. But also you can hear Dr. Gene Buckman, who's the executive director of the center, on Saturday, where he's going to be presenting about how the model is working and how we're expanding to almost 29 countries now. So that's it, and I'm happy to answer any questions. But before I close, I want to also dedicate one thing. A lot of people must have told you, you have diabetes, you can't do this. You have sickle cell, you can't do this. But I just want to say, I was told multiple times that I can't do this. I face stigma, but I want to dedicate something to each one of you, and that is that I ran the New York City Marathon, and I couldn't have done this without each one of you. Thank you for helping me cross that finish line. This is a dedication to each one of you, that you are capable of so much more. So thank you.
Amazing. Thank you. And congratulations. That was just over the weekend, wasn't it? Yes, amazing. We are going to do questions, but we'll have a panel discussion at the end. So please note down your questions. If you're watching from home, you'll be able to share your questions and we will be able to get to them later on. Thank you so much. Okay, we are going to Jerome, you're up next. Would you like to come up? And your presentation is here. Thank you so much.
Good evening, everyone. Thank you, dedoc, for organizing this symposium, and all supporters. My name is Jerome Kazabukeye. I am Burundian, and I have type 2 diabetes for 7 years. Today I'm going to talk about my experience and the achievement. And my journey don't begin in this conference room. It has begun on May 25, 2018 in the doctor's room when I heard a word diabetes. That was a huge a huge word for me. I was afraid. I was feel alone and afraid of the future, and that's why I now I can say that I am changing the life. The Canada is changing my life, and Quebec in particular. Here I can say the dual perspective as a result of this personal journey. One as a person dealing with chronic disease, another as a member of online communities for organizations which advocate for people who have diabetes. I have initiated the Refugee Diabetes Club in 2019 in Rwanda, where I was a refugee and helped many pairs to awareness, diabetes awareness, and now I'm founding Refugee Diabetes Association, which is registered and incorporated in Canada, and we are dealing in Quebec incorporation. That can be a parenthesis. Now I'm going to talk about what I wish you to know today. To have diabetes when you are depressed people, it is a socio-economic disaster. It is a very difficult word to be a person depressed and being also diabetic. It is more than medical issues, as you can understand. The challenge is the impossible choice, a gap, an invisible option that a human perspective. Every day, the depressed person must take impossible decision. Do you buy child shoes or test strips with remaining cash? Do you buy a child? Do you and your family go hungry, or do you consume the lunch you get, which can raise blood sugar every day? Isn't abstract. This is experience I lived, and I gathered the information from my parents, refugees who are in East African countries, and they have every day to deal with those impossible choices. Those are inability to pay for medication, a critical shortage for financial resources, lack of monitoring access, and nutrition insecurity, and obstacle to practice physical activities, and the stress for unemployment. You know that with artificial intelligence nowadays, the jobs are not available for every citizenship, for every country. And in low-income countries, the refugees don't have to work. The first thing I would share today is the importance of psychosocial support as a clinical necessity, not soft care. Second, I wish you to understand that the importance of health care, people who are depressed are always on move. They move from camps to urban area, from nation to another. They don't followed by one medical record every time they start. Even me, when I came here in Canada, it was like the start while I had 7 years of diabetes. The diabetes management. I am here today to ask for policymakers to take a decision. I strongly urge the non-communicable disease care to be integrated into phase 1, every human response, rather than being treated as after in low country, in low income countries. To ensure this continuity of care. For researchers, additional data are required. The effect of socioeconomic and social intervention, long-term clinical outcome, such as hypertension and other comorbidities, must be measured. For industry, I require importance innovative diagnostic therapeutic technology that reasonable price, and make it accessible and not complicate the supply chains. In summary, treating diabetes in a depressed population involves more than writing prescription. The goal is to restore dignity of a depressed person who are living with diabetes, and the main clinical factor that need to be addressed, clinical stress. Additionally, ultimately, a goal is to build a health system that treats a whole person, not just diagnosis. Diabetes management is inseparable for a person's financial, social, and psychological well-being. I let you this contact who need information or who need to contact me. Kazabukeye, and then I'm building also kazabukeye.com, which as my portfolio. I've forgotten to disclose my conflict of interest while it was recommended. Now I am a member of the dedoc community online and Blue Cycle Voice, and I am founding refugee association, Refugee Diabetes Association, Refidia, which is going to be registered in Quebec. And I'm also a job seeker because I'm new here in Canada in digital marketing. If you have a job, don't hesitate to hire me. Thank you.
Thank you so much, Jerome. One of the things that we've tried to do at dedoc is to make sure that we are sharing stories from very diverse communities, because everybody's diabetes is different, and a lot of that difference and what that experience is due to the circumstances of where we are living. And sharing your story, thank you so much for doing that. I think that we often forget when we're talking about the latest shiny gadgets and the latest in technological advances, that what people have access to is very, very different. What people's experiences are very, very different. And we need to be going back and remembering what people are actually living with on a day-to-day basis. And thank you so much for doing that, for your experience. And I really do appreciate that. So thank you, Jerome. Okay, before we get to our Q&A, so remember, we do have time, well, there will be lots of time for questions. Paul Louis, would you like to come up here? Is it Control L layer? I think that's what we need to do to make this happen. Look at me with the technology. Thank you so much.
So my talk is going to be about leveraging the skills and life experience of people with type 1 diabetes to improve care and outcome. So I've been living with type 1 diabetes since more than 27 years now. I feel very lucky because I'm born in France and so I have access to all the best diabetes care. And I've been involved with national association like AGD to work with doctors to improve diabetes care. I'm also involved in INODIA as a patient advocate on screening, and so I've been working on a lot of topic with co-creation, and also 8 years ago now I started in Madagascar a project on access to diabetes care. When I was there, I met local doctors, and at this time people didn't really have access to insulin. All the kids were almost dying or dying in a few years, and we launched Life for a Child, Insulin for Life, and it changed everything. And now, so when we speak about improving care and outcome, we often think about time in range, A1C, fewer complications, but there are also other things. There are also other things that are important, like time in happiness, and by improving care, we also it's about the processes, also the interaction and the experience of the patient with living with type 1 diabetes, and the outcomes is the result of the care. And something we have to keep in mind is that we have to ask also ourselves, like I mean. More for healthcare professionals, that non-compliance is not about a choice. It's usually, I mean, people they are not compliant maybe because they are worried about the affordability of insulin. They have fear of stigma. So so for example, in Madagascar. Madagascar, the situation has improved a lot since we started Life for a Child, but still it's very difficult. But one of the issues there was with the students is that they were not necessarily injecting insulin at lunchtime, because when they were using a syringes, everybody thought that they were taking a heroin or something like this. So and also me, when I was younger, when I got diagnosed, I didn't feel like supported by my doctor. I had only my doctors and my dietitian. I was not for them. I was not necessarily very compliant. I was going to the consultation. I was filling my diary just in the waiting room. I was also inventing my insulin doses, like I guess many people did in this room. But my doctors never asked me if the results were true or not. And also I was seeing the dietitian, and my dietitian was just giving me a paper with what I have to eat, and I was going out of the consultation and just throwing the paper. So it was just a waste of time and energy. And I think nowadays when I see my doctors, it's totally different. We don't speak about numbers. We almost never speak about. I just mentioned my A1C, but we don't really speak about this. We speak more about my life, my challenge, and I think this is very important. And the number is not like the glucose number. It's not. I would say it's more like the destination. But what is important is also to focus on the road. And on the road, there are many challenges, like for people living with diabetes, but also for the healthcare professional. So you are asked to do more with less. So there are more and more people living with diabetes, and there are not necessarily more resources to handle this, access to technology or even to medicines is, I mean, in France we are lucky. In some other parts it's very difficult. But also in Canada, like I learned yesterday, only 20% of people have access, I think, to CGM. So also in high-income country, access to technology is not guaranteed. So there are a lot of challenge for this. There is also a big gap between the theory of managing diabetes and the real life. Many people with diabetes, they feel isolated or lonely to manage their diabetes, and also the target are many of the targets that are discussed with A1C of 6.5. It's almost impossible to reach for most of the people around the world. So there are a lot of challenges, and I think something we need to, the resources that are not going to change in the near future. I don't really believe that, and I think that maybe we have to ask ourselves if the next revolution cannot come from the integration of people living with type 1 diabetes in the care system. And so now you might be wondering why I'm showing why I'm showing a chameleon from Madagascar. So this chameleon, he represents someone. He represents someone living with diabetes. So as a person living with diabetes, we constantly need to adapt, like the chameleon is doing in its own environment. And additionally, what you see as a healthcare professional, it depends on the question you ask, the relation you have with the person you treat. It depends on the emotional state of the person, and also like people with diabetes, they have a lot of diverse skills, professional and other skills. And if the healthcare team is only focusing on the type 1 diabetes, we don't see these skills that can be also used to improve the health system. And now one of the questions is how can you involve the people with T1D to improve like the care and the outcome, and I think these are a few steps that you can do. It's so you can first start by identifying the opportunity to include the live experience in your practice. So I will have a slide after where I will give more information about this. You can also identify people that could be suitable to help you. And these people, they need to have time, they need to be motivated, they need maybe to have special skills depending on the projects. But a lot of people with type 1 diabetes, they are willing to get involved, but they don't know how to do, and they would like to support the community, but it can be also very, very different to start. So I think also the healthcare professionals have a big they can have a big influence also to encourage people to get more involved, to support the community. And I would say when you start something, you can, the best is to start small and to scale later, because too often we try to do a project and it totally fails because it requires a lot of resources. We get burnout. We have so many also diabetes advocates that get burnout. And I think it's better to start small, and that it will take, it will go slow at the beginning, but this is how you make something sustainable. And also you need, I would say, as a healthcare professional, when you work with people with diabetes or trying to get them engaged to improve the care and the outcome, you need also to trust them. And I think if you give them the trust, people you trust, of course, you will be surprised by the results. And these are some examples of opportunities on which people with live experience can support you. So it can be by making clinics visit more patient-centered and collaborative. So this can be very simple. You can have a board of people living with diabetes that are going to to advise you on how to improve the practice. You can also ask feedback to your, I would say, to your patient when they come to visit you. Ask feedback about how they feel. Do they feel what can be improved? About this, I had a very, I had an experience when I was living abroad. I'm not going to mention the country, but so I was expat like a few years ago, and I had to. Normally, I was seeing my doctor in France to get my insulin, but one day I had a big problem with my insulin. All my insulin freeze, and I had to find insulin in the country. And I went to see the doctor, and there was like 20 people queuing. So there was no appointment, 20 people queuing. But the thing is that there was no privacy. So you were in front of the doctor, but there was one people 50 centimeters from you just queuing. And so in this case, in this kind of setting, it's very difficult, I think, to have also that it's very difficult to have confidence, to have results, and I think like if the doctors or maybe the hospital ask feedback to the patient, I think this could improve a lot the outcome also. Then there is another very powerful tool where people living with diabetes can help is peer support. Peer support can change a lot. There's various forms peer support can be done. It can be done online. It can be done by organizing physical events. It can be very simple. You don't necessarily need money. This is something that I've been doing for a few years in France. I was just organizing like Jab After Work. So it was after work for people living with diabetes or people that want to come. There was no... it was for everyone, and people were coming. There were no topic. There was no topic. You didn't need to speak about diabetes. It was just it was just people sharing their experience. They are speaking about diabetes or not. And I think when you put all these people in a room with type 1 diabetes, they will connect and they will share. And the advantage is that it's not about just theory. It's about what really work, and I think the doctors also, especially in a country like Madagascar or where you have very limited resources, peer support is something that the doctor also should encourage, because it can have a huge impact. You can also integrate people for designing care program. For real life challenge. So, for example, in Madagascar, they are doing like they are doing education. They have designed a program for students where you have therapeutic education. They have designed it with students where they answer the different needs of people with diabetes. And it's not only about diabetes, it's also skills that will help them in their daily life. It's also psychological support. So it's a lot of things also that is helping a lot the people with diabetes. And there is a last point, it's about co-teaching. I think, we as people living with diabetes, we learn a lot from our healthcare team. But we can also teach a lot to our healthcare team, and I think it's important also to train the team, the medical team. So, for example, like this year, I was very lucky, but I was with Emma Clapland from Life for a Child, and we did a kind of training session for nurses in a country in Africa. I don't remember which one, but we shared our experience to. And I think this is very important to improve the care, also to have better outcomes.
We're very much at time.
Okay. So the key takeaway, it's my last slide. So I think it's, you should learn from your people living with diabetes, but it goes in both sides. It's we should learn from each other. I think we need to also, as healthcare professionals, give space and trust them. And also something very nice is that in this conference we see a lot of doctors or healthcare professionals with type 1 diabetes. Most of them are coming from rich country, but now I think especially for a country like Africa, in Madagascar, we have people with T1D now, which are studying medicines. They want to become doctors or nurse. And I think it's very important, especially in this country, to have these people with the theory and the live experience, and it can have a lot of impact.
Thanks so much. Thank you so much. Now we are going to do a Q&A. So this is the thank you. This is the audience participation part of the program where you get to ask questions. And please do. I mean, you have an opportunity now to speak with people with diabetes and ask some wonderful questions about the work that they are doing. But while you are making your way to the microphone, I would like to just take 2 minutes to talk about a very exciting initiative that is happening next year in Jaipur in India in March. And that is the global summit, the first global summit to end diabetes stigma. So I should declare wearing my other hat, which is my day job. I work for Breakthrough T1D in the Global Responsibility team, and we are delighted to be funding this. And it is being coordinated by a vast group of people. Lindsay is one of them. And this summit is addressing and looking to address how do we end diabetes stigma. I can't count the number of times we mentioned stigma today. I gave a talk on it earlier. It is certainly something that is relevant to so many people living with diabetes. And this summit is looking at finding solutions of how we end diabetes stigma. So I would really encourage you to please have a look at the website, enddiabetesstigma.org. And while you're there, sign the pledge if you haven't already done that. There is a pledge to end diabetes stigma that's been, it's been live now for over 2 years. We've got 3,400 individuals who have signed it. I think it's getting very, very close to 400 organisations in 116 countries now. If you haven't signed it, please do. If you have, go and find 3 people who haven't and ask them to sign it as well. We really do need to end diabetes stigma. I think we can all agree it is harmful, it impacts us in very negative ways, but we now need some solutions, and that's what the summit next year is all about. I'd encourage everybody to write an abstract if you believe that you have something that should be discussed at the summit, and the abstract portal is now live if you go and have a look at the website. It's all on the enddiabetesstigma.org website. Also have a look at the consensus statement that was also launched a couple of years ago now. And I'm thrilled to say that there will be scholarships available for people with lived experience of diabetes from low and middle income countries. So watch this space because there is more about that coming, but it's very, very exciting. Okay, now it's time for a Q&A. And I know that it is 5:30 p.m, maybe even a little bit later, and I understand that it's probably been a very, very long day, but we would love there to be a bit of a discussion and some questions. And Fergus has made his way to the microphone, so you can start. Let's go.
Move the microphone a bit closer to the front.
No, it's good to get your steps up.
So this is a question that's a bit left field, but this is the right place to ask it. What do you wish we knew as clinicians about artificial intelligence? Because artificial intelligence is already here. It's all in our phones. It's in your devices if you're wearing a pump. But it's about to move into clinic consultation rooms. It's about to overhear our consults. It's about to move into decision support devices and things like that. And it is coming fast. And whether we like it or not. And there's a whole raft of issues that come with it, with ethics of it, the equity aspects of it. And I'd be really interested to know what you think we should know about it.
I love this question, and I am willing to bet that at diabetes conferences over the next couple of years, this is going to be one of, if not the most, one of the sessions that is going to be everywhere, and everyone wants to know the answers. So who wants to have a go? Lindsay, you look like you'd like to. Let's start with you, and then Paul-Louis. And please do speak into the microphone when you're sharing your answers.
I appreciate that this is coming up in the questions. I'm going to answer first by challenging that it's coming soon and say that it's been here for a while. We were in Chicago for ADA, and the only reason I had deep dish is because I asked ChatGPT what the heck to do with my pump settings, because I've put my AAPS documents onto ChatGPT, peer-reviewed published papers, and instead of spending 9 hours reading those papers, I've been using AI for 3 years actually to read them, and I'm not alone. I think it's phenomenal to think about equity concerns about AI. AI is a phenomenal equity bridger as well. My fellow advocates who live with vision loss, the reason that they have certain jobs that they do now is because of AI tools that help them manage their vision loss, their diabetes, and their work. So I think the question becomes, first, while we meet people where they're at with their diabetes, let's also meet people where they're at with their AI usage, because I think there's a lot of shame and blame when it comes to the AI discussion as well. Oh, well, you're using that thing for that medical decision, or you're using that to calculate your bolus. Well, yeah, I am, because I'm tired and it's a tool. So either we come together around a table and figure out, okay, how can we use this that in a way that it serves the entire community where we need it most. I think there's some phenomenal work being done. I'll shout out that one of our projects this year in partnership with Children with Diabetes is an AI bot built by people with diabetes to help people choose the right pump and sensor for them. And it's all closed, evidence-based, research-based, because people are using it. We just need to have all the folks, including folks that are using it imperfectly, at the table.
It's a great answer. Thank you. And yes, Paul Louis, you want to add? Just start speaking and it'll
go.
Yeah.
So I will answer you as so I work in I do data, software, and AI engineering. So I can answer you also on this. I think AI is a big chance, and it can solve a lot of problems, and it depends how we use it. So with AI is very broad. I mean, we speak about LLM like ChatGPT, but it's a lot more than this. The thing is that with AI, we have to be careful, because it can be good as it can be bad, and I think it depends of the usage. But if it's well designed, well used, it can solve a lot of problems, and I think it can be very, very useful in a LMIC country.
Yeah, I really appreciate the question, because I had a conversation with an endocrinologist in Australia who I'm not going to name, doesn't matter how much you ask, who was adamant that it would not be in the clinic setting, that they would not be using it, and it will not ever be used in a way that is meaningful, because there are too many dangers. And I feel that that is such a naive way, but, burying your head in the sand never works. So I'm, concerned that that was their approach. Did you want to say something, Apurva? Yeah.
I just want to say, even though there are two schools of thoughts around it, just a positive side of it, I used AI for designing my fuel plan for running a marathon, because I thought I could not afford professional training to run the marathon with diabetes. And I just asked ChatGPT that, can you please design what fuel plan I should follow so that I don't injure myself and I can attend ISPAD without any injury on second day of the marathon. So I am still standing here because ChatGPT helped me every 3 miles do this. And my blood sugars it's so strange. During training, never. My blood sugars were straight line. But during the marathon, if you see, during those 4 hours, straight line graph without doing any intervention, just following ChatGPT. So if it can help me, probably it can help so many other people. So I think you can use it with a pinch of salt, but also it's a great way, like an equity bridger. I really agree that.
So Fergus, can I ask what you get when you hear that? Where does that... What do you think now?
What I get there are 4 sort of personal stories of. I think there's the 4 categories, aren't there? There's the doomers, the gloomers, the boomers, and the zoomers in terms of your uptake, your attitude to AI. And I hear what you're saying. I mean, it's been here for a long time. I mean, ChatGPT is years old, and we're all using it. Well, not me, but other people are using it, I believe. It's going to, I think, profoundly change your agency in terms of your control over your own sort of situation. It's going to profoundly change the way you interact with health systems and healthcare professionals. that's all I can say. I don't know how it's going to affect it. I just know it will. And like all things, it might be for the better. It might be a mixed bag. But it's stuff I think we really need to be thinking about. And certainly ISPAD we're forming a whole subcommittee about it to consider it, because there are some pretty profound issues at play there, I think.
And I bet you know that I'm about to say, and make sure you include people with diabetes on that committee. Can I say that there's one thing that I find about the diabetes world, and I bet that this is just a world in general sort of point, but anytime there is something new in technology, there is fear. And I just want to remind everybody that when home blood glucose monitoring, back in the 80s, I didn't have diabetes then, but when home blood glucose monitoring became a thing, there is an article and there is a quote from a clinician saying it's a dangerous practice. It's a dangerous practice. So my comment always is obviously consider the warnings, consider the dangers, but certainly don't be closed to anything. And I think that where we'll see how any sort of technology is being used is from people with lived experience who are trying desperately to make diabetes easier in some tiny little way.
Yeah, and I think also mics are not on our side today.
Can we have the mics on at the table, please?
Hello? Okay, perfect. I think dangerous to whom and to what? Yeah. Because it's sometimes dangerous to the right thing. So I really appreciate the point about agency. There's a group in Canada that's had an AI app for doctor's appointments. It's been piloting, and I forget their name. I'll pull it up. But the app basically says back to you what your concerns are as a patient, and then says it back to the doctor and integrates it into your chart. So it first asks you, do you feel heard and seen about what your issues were and were they addressed? And then it integrates it into the chart. I think that is dangerous to the bad stuff in the system of, like, as someone who took forever to get diagnosed, I wish I had that, I wish someone put in my chart that I wasn't being heard. So dangerous to whom and to what? It's not always a bad danger.
Yeah, that's really great. Hi.
Julia Vonetting from Montreal. Thank you so much to all of you. This is inspirational to have dedoc and ISPAD collaborate like this, and I'm loving it. And thank you also for one of you who were on the scientific committee, plus some additional voices. That was, I think, what shaped this conference, so thank you. On the AI piece, I have to say I do incorporate it, and I encourage my patients to use it. I would challenge the notion, though, that it universally reduces the equity gap. I would say for some of our patients, it actually increases the equity gap because they don't have the facility to integrate this into their daily lives. If we speak about technology use, AID use, it's the same thing. The reason why kids with the highest A1Cs are not getting, the ones who need it the most and would benefit the most are not getting AIDs are systemic barriers. So my question to you is, and I'd really love answers, how do we make sure that dedoc and in general, patient voices are really representative across the spectrum of patients that we have? That's number one. And number two, how do we make sure we can get these voices into our clinics? I would love nothing more than to have voices like yours in my clinic every day. We're working on a patient advisory board for our clinic, but who are the people that we should get on that board? How do we pick them? How do we best work with them? How do we keep them motivated and keep them from getting burnt out? These are real questions, like how the collaboration works both ways. I have to say it's not always easy to get people like you to collaborate with us and to foster that collaboration in a productive way for everyone.
I'm throwing that to you, Lindsay.
Yeah.
And
I have thoughts.
I know. And so can I say just two things about this?
Yeah.
And then I'm going to throw it to you. Firstly, I love this question, and thank you so very, very much for having this discussion and putting this on the discussion agenda right now. And I want us to answer. My 2 points are going to where people are, because what I just heard is how do we get people to come into our clinics? Maybe that's not the way to actually get people to engage. So that's the first thing. But the second thing is that one of the things, we put this burden often on people with diabetes to fix this issue. And it is a massive issue because, quite frankly, I don't want to hear from people like me. I'm sick of hearing from people like me, right? But we're the ones who show up because we like to come to clinic. It's a safe place for us, or it's a place that we feel we can navigate. So now we are being asked to fix another situation. And I want Lindsay to talk about this because I know that this is certainly something that you have spoken about before in a dedoc context and more broadly as well.
Well, first, I want to clarify that I don't think there's anything that exists ever that is a universal bridger of equity gaps. So I want to clarify my words and say that it bridges equity for gaps for some folks and exacerbates others. The other thing I want to say is my first recommendation is approach with curiosity and not assumptions. I lead the largest patient engagement chronic disease network in Canada, and I've never volunteered for a clinic advisory board because it's so hard for me. For many of us, those spaces are not safe. The power dynamic is often not in our favor. And when Renza says meet us where we're at, I think what that operationally looks like is form partnerships with organizations like dedoc, like Diabetes Action Canada, and let us do the work and the relationship building that we've been doing for decades. Because the community, it's much easier for me to call Renza than it is to call my own endo. And I'll also say, like, I'm pretty open and say it took me a year and a half to build my AAPS because I was so mentally burnt out. So just because we're up here doesn't mean that we're that different from the rest of our community. I still am not done my objectives. And on paper, I am the perfect patient. But it would be, like, I would never put my hand up to volunteer for my clinic. Would I put my hand up if dedoc or DAC or another trusted organization was like, hey, we're gonna foster and build these bridges, we're gonna facilitate this relationship, and we need your expertise? Absolutely. I think that's really important, and I think also leaning into those trusted relationships to help you navigate who needs to be at the table and how to keep them engaged. The one thing I'll say is we have to pay folks. We have to. Like, this is work. Every single engagement that we do at DAC is paid at a minimum of $25 an hour. There is no such thing as free work. And I would say that we're still not doing good enough. I have to take time to be here. Where are my kids gonna go? Who's gonna take care of the home? Who's gonna do all those things, right? So there's a lot there, but I hope that it gives you a seed of where to start.
And I think one more thing is that if we give time for this, we need to feel that we are listened also, because sometimes we participate to some board or different things, but at the end nothing happen, or we feel that we are just here for the picture and it's nice, but it's not useful. So I think it's very important also to have when we participate to this, that our voice is heard.
Okay, I can add something. As a refugee, when I was a refugee in Rwanda, I got a scholarship for dedoc first, and online when I was speaking, I heard by many organizations, and I was contacted, and my peers are being supported because of my voice, and also when I am feeling that I am a human, it is important more than what you can think. Because when you are a refugee, sometimes you think that you are not normal, you are not a human. And when the dedoc voice or other organization invite refugee to speak, it was a great thing to them. Thank you.
Thank you, and thank you, Julia, for that question, because that's a question which I also battle with the Voices for Pen Plus, because I feel like there are certain people who are represented at every conference. They're like the privileged, like we all sitting here are the privileged people that we can really talk about it. But the real people who have that challenge of living with diabetes are the ones who are living in rural Haiti or Malawi, who are still battling just getting food on the table sometimes. And how can I bring them into advocating while they're still struggling to get food on their table? So I think with the Voices for Pen Plus, like when we really think about how we can bring more voices, support them, bring them in clinics, and really help them as a key stakeholder is like just asking and listening to them, capacity building, helping them understand that this is how you can use it. And that's what I've been doing. We are really investing on capacity building people, to supporting them not just in their clinics, but also outside through advocacy, through understanding that this is not a limitation, but this can also be something which you can support others. And I think everyone's experience is so unique. Like I've been so lucky to learn from so many people working in Mozambique, Malawi, all the voices, because they bring so much experience, so much expertise, which I probably never read in medical books about diabetes. And that's what is so fascinating. And I think what everyone here is trying to say, that we really need to value that expertise, be it through a value of compensation. I think we really need to think about how we can be innovative about it, how we can bring it on the table. Yeah.
Thank you. Just a quick follow-up. This is, for me, this is all about the bridge, right? How do we build that bridge between the lived experience community and the healthcare professional community, so that we can feed off of each other and really bring in the things that you are missing in your appointments, the things that you want from your healthcare providers, to really get that to the healthcare providers in a platform that works for you.
I love that idea of there being a bridge, because a bridge goes two ways, right? So I think that that's really, really important to consider. And I want to say that every single step does help. So ISPAD having people with lived experience on the organising committee, that is massive, because that simply didn't happen. We know that with EASD last year, a partnership with dedoc was announced to help to make sure that in guideline development there will now be people with lived experience as part of the guideline team. And again, that talks to dedoc is really well placed to find the right people who are relevant to that guideline, who can actually speak. It might be harder for the person who is there, who is in charge of actually writing the guideline. They might not be able to find the right person in the community to do it, but dedoc probably can. So those sorts of relationships are so important. So once again, a huge thank you to ISPAD for really being so responsive to developing this relationship. And we say the same thing to the team at EASD and ATTD, because these partnerships are so important. They are absolutely important for us, but they are also important for your societies as well. You know, that two-way bridge is really, really important. Yes, please go to the microphone if you've got a question.
Is that two-way bridge also just accepting that maybe it's not the task of the doctor, or it can't be the task of the healthcare professional to do it all, because maybe we are overestimating ourselves? So I can see that, and I had some discussions with some of you before, that nurtured me in a sense, that there are many patients who just don't even seek our advice or tell anything, because they have lived experience of interactions with doctors that they think, oh, they won't understand anyway. So why would I risk another battle? Let's pick my battles. And then they use AI or others or Insta to type in what they are looking for, and then they reach out to somebody who they can talk to. So if that is a better solution, who are we? So I'm a medical background. Who are we to say that we should also bridge that? Could we not accept that apparently we have a very large blind spot of things we don't understand, but that the community who has the 4 L's knows and has the capacity to seek that somewhere else, and that's okay too?
Oh my goodness. Wow. Yes, let's talk about this.
Hello, my friend from lunch. I think first, thank you, because I think what I'm hearing you saying is, does the healthcare professional community want to own the bridges or travel on the bridges? And I think that's a very important thing to reflect on. I don't think that doctors and nurses and OTs need to own the building of the bridges, but I welcome everyone to use them. I want everyone to cross back and forth. Maybe for some, in seasons in your practice, you're walking over the bridge and listening to us tell you about our massive online Instagram community. And maybe some seasons of the bridge, you're putting bricks and filling in the gaps when that bridge needs reinforcing. But I think we all need to reflect on, I don't think the research or medical community needs to own the bridges. I think they need to help us in building them together and then finding ways that we can all travel back and forth.
Yeah, does that include that if somebody is looking for bread, you go to a bakery, and sometimes patients come to us, whereas we are not the bakery, but they are looking for some piece of meat, whatever, and it's fine that they then go to a butcher shop. But if we don't have the mutual understanding that that's not our shop, then the expectations go high and the disappointments go very low.
I would say that's true vice versa. I encourage healthcare professionals to also reflect on the expectations that you have of us, because we are finite and mortal too. So I think in general, that reflection around expectations is wise.
Thank you so much for that. I think that's such a valuable conversation that I feel may have been massive at lunch. We've picked up on it here, and we're still going to be talking about this for months and years to come. So, and I look forward to quite frankly, I look forward to the Instagram conversations about this that are going to happen from people who have been taking photos and are going to be taking notes, and it'll probably be on TikTok too, but I won't say that because I'm too old. Okay, so have we got any last questions? Yes, please go to the microphone. Thank you so much. Sorry, why haven't we got the microphone down the front? Okay.
Hello, I'm Monica and I'm a dietitian from the UK. And I just wanted to kind of address this last kind of question and discussion. So I'm working on a project on co-producing exercise, so physical activity support for our adolescents with type 1 diabetes from ethnic minority groups. So this topic is really like, you know, I'm kind of, you know, picking everything up and putting in my brain and trying to store it all, because I want to do it well. I want to work with our patients and families the way they want me to work with them. And I feel like that little in this whole project, you know, I need so much help from our patients and families. And I feel like, I don't know why it's me doing this project, but I feel like, you know, it has to be me, and I want to understand it well. So I've been talking to a lot of people about it. And I think, you know, for me, we are like family, you know, in a way, like us healthcare professionals and patients and families, it's like one whole, maybe family is a big word, but, you know, we need to work as a team. So we can't just say, oh, is it me or is it you that's going to do it? We need to do it together. And I feel like, you know, a lot of our patients don't have the confidence to say what they need and to say what they want. And if it's not me going to them and say, you know, this is what I'm hoping to do with you, but how do you think we can do it together, and can you help me do it? They're not going to come to me and say this is what they need. So in a way, you know, with those bridges and building the bridges, it feels like, you know, healthcare professionals need to open up a little bit to the patients, like me, like us, like my team. We need to be able to ask our patients what they need. Because we can't just ask our patients, please tell me what you need, you know, and come to me when you need something or you need me to do something differently. We are the ones that need to stand up and say, we need to do something about it, and then work together. Because otherwise we won't change anything. We won't improve things. So just wanted to say that that's how I see it. We need to do it together, basically. So yeah.
Thank you. Thank you for the comment. Yep. Okay. This is going to have to be our last question. Go. Yeah.
Yeah, hi, I'm Laurie Lépine. I'm from Montreal. I work with Lindsay at DAC. I'm a patient advocate and I am also an OT. So what I wanted to ask you guys and add a bit of reflection is we talk a lot in the last questions and during your presentations about open discussion, enabling a space where patients can speak. But I, as an OT, I'm all about like concrete steps and clear steps and like, what would be your basic advice? What question as a patient partner would you like to receive? Or not even as a patient partner, as just patient dot. As an OT, I literally ask my patients, what are your needs right now? What do you want to do? And not even about the specific disease or affection they have, but just in everyday life. And sometimes they just tell me, well, right now I just want to be able to walk and go to school without being stressed. Okay, it's not about other things that I'm supposed to talk to you about, but this will enable you to be better and feel better, and after we can take those steps and go further. So what questions would you like to be asked?
This is such a great way to end this session. So if we can think of one question that you would like your health professional to ask you, it can be any health professional, to ask you when in a clinic setting. So I'll just start by saying I know that Bill Polonsky has spoken about this, and he asks the question, what is really annoying you about your diabetes right now? And I love that, because what a great way to start instead of show me your A1C or show me your numbers. So it's such a great way to open a dialogue and give people space to say, actually, there are things that are really frustrating me right now. Okay, if you can think of something, if you can't, it's fine. But what is that question that you would like to be asked?
I don't have a question, but I think the most important is to build trust between me and my doctor. And I think when there is trust, sometimes the doctor don't need to ask any question. You are going just to say what is the problem or what you are going through. And so I would say, as build trust with your patient, listen to him, show him that you care about him, and yeah. How? Yeah.
I like that. Okay, have we got any other ideas of specific questions?
I can go, and I wear both the hats. So, as a clinician and also as a patient, I think one thing I would like, and I'm a very checklist kind of a person, so I would want, as a person living with diabetes, to make that mini goalpost and just ask, what is one mini goalpost? And that goalpost could look anything. It could be just, oh, I'll just test my blood sugar 3 times. Or maybe I'll start changing my Lancet. That could be a mini goalpost. That's basic.
Ambitious.
Very ambitious. But like making that mini milestone moment and then celebrating that milestone moment, because the joy of celebrating that milestone moment is both ways. As a clinician, I love seeing if somebody improves their A1C or the time and target range improves. Like, that's beautiful. And the person also feels empowered. And it's a celebration. You have to celebrate those mini milestones. And I think that's what works for me personally. And I would suggest the same for anybody.
Please if you're a clinician, ask your patients nothing about diabetes to start. Say what's exciting you in your life right now. I had a doctor that would ask me that every single appointment. I was telling Renza, I downloaded my medical file when I had her as a doctor for 2 years, and she literally wrote down when I got my internship, when I got engaged, when I planned my wedding, when I got my promotion, and the next appointment, the first thing she would say is, how's the internship? How's your engagement? How's wedding planning going? And then she would ask me a clinical question and write it down in the chart, because that's an actual operational way of humanizing your patients. And the other thing I'd say is, don't call them your patient, just call them by their name. And if you work in research, I always tell people I am not your patient. I am only a patient for about 27 minutes a year when I see my endo. No shame for the 27 minutes. At a minimum, say patient partner, research partner, community partner, advocate, but language really matters.
Thank you so much. What a way to end. Unless, yes, no.
So
I'll
I
make
didn't
it quick.
fully answer your question. So I would say a bit like Lindsay. So we all have different goals, and I would say instead of speaking about diabetes, it's about focusing on our goals and to see how we can reach them. And I would say the healthcare team is also here to help us to reach our goal. And I would say if we can reach our goal or see that it's possible, we will be also more likely to reach the glucose target, better glucose target. So.
Yeah. Thank you so much. Please, please join me in saying a very big thank you to our amazing panel today. Please join me in also saying a huge thank you to the dedoc team behind the scenes. Actually, in the room, we have Anna and we have Leah. Thank you so much. We have Grania, we have Bastian at home, and Jean was also a very big part of this. So thank you to the team back home as well for making this happen. And thank you to the audience for taking time out to be here and to listen. And sometimes we have uncomfortable conversations in this, but I think it's all about actually making sure that we have that bridge being built and solidified, and so that we are working together. Thank you so, so much. Enjoy the rest of the conference. Fergus, thanks so much for hanging around and for managing to stay awake at this witching hour for us, isn't it? Please go and give him a pat on the back and saying, good on you for the jet lag management. Come and tell me that too. Thank you so much. Oh, we want a photo. Does of who? Everyone. Everyone who would like to be in a photo, and absolutely if you've got lived experience, loved experience, learned experience or laboured experience, which is every single person in this room, come down to the front so we can get a photo, please.